Yes, Kennedy, how are you?
Fine, Simon. How are you?
Very good, very good.
So on Saturday, you are monitoring YouTube from which cloud? Were you in Kaponja?
Baadaye webinar imeanza, tutaongea hapo kwa kona.
No, webinar, we have 5 minutes.
Okay.
Yes. Good morning.
Welcome to today's webinar. We're going to give other attendees about 2 or 3 minutes to join before Dr. Onyango takes it off. Karibuni sana.
Okay. Good morning. Good evening, ladies and gentlemen. Peter, am I audible?
We can hear you.
Thank you, Caesar. So I take this opportunity to welcome you to this national webinar, which is being hosted by KMA KISUMU Division together with the KMA National Office. My name is Dr. Kennedy O. Onyango. I am a gynecologist by training. I'm a lecturer at Maseno University. Currently, I'm the treasurer KMA KISUMU Division, and I also coordinate the CMEs. Today's CME is being hosted by KMA, supported by PFIZER. And in this regard, we are going to have a main speaker today, Dr. Caesar Bita. I will be the moderator for the session. Kenya Medical Association is the premier umbrella professional body of doctors in the country, and it has a long and rich history. I'm not going to talk about the long checkered career of KMA, but who is who in the medical profession in Kenya has been in the Kenya Medical Association. And if you are not a member of KMA, then you are really missing a lot. In fact, we say that you should be a member of 3 bodies as a medical practitioner. Kenya Medical Association as the umbrella body of doctors, Kenya Medical Practitioners, Pharmacists and Dentists Union as the union umbrella, and then the professional society. Myself as a gynecologist, I'm a member of COGS. We have surgeons like Caesar Bita being members of SSK. We also have others who are going to be members of Kenya Dental Association, Kenya Orthopedic, etc., etc. KMA is the first one to embrace devolution, and it is successful at that. That is why KISUMU is one of the divisions of KMA. We have Nairobi Division, Coast, Nakuru, Eldoret, Kitale, and many others. So today I'm going to be moderating. We have Dr. Caesar Bita as our keynote speaker. Dr. Caesar Bita is a consultant general surgeon. Currently, he is a council member of the Surgical Society of Kenya. At the same time, he is also the chair, Department of Surgery and Anesthesiology at Maseno University School of Medicine. He is going to talk about updates on management of surgical skin infections. After Dr. Bita has given his talk, we are going to have a talk by PFIZER, who is our sponsors. At the same time, we encourage members, if you have a question, please post it on the Q&A button, which is present on your laptop. But if you are not able to see the Q&A icon, please, you can post it in the chat. We encourage that we give our keynote speaker enough time to do justice to his presentation. And then at the end of it all, after Dr. Caesar Bita has presented, then our sponsor is going to have a brief presentation. Then we are going to take all the questions together. I've already seen a peek preview, somebody asking about the CPD points. Yes, this is an accredited webinar. It is going to have CPD points. So if you registered, then through the contact that you gave us, you should be able to receive your CPD tokens by end of the week. I think without further ado, I will ask Peter or Caesar Bita to start sharing Caesar's slides, and Caesar Bita, you can take it away. Karibu sana, daktari.
Thank you, Dr. Nyango, for that very generous introduction. I want to thank KMA for considering me to give this topic. It's an honor. And my topic today will be on I'll be giving updates on skin and soft tissue infections in adults. And a lot of it will be our local scenario and setup. To start off, I must make some disclosures. My affiliations are to Maseno University, where I'm chair of the department, KISUMU Specialist Hospital, where I'm a CEO and a shareholder, KMA KISUMU Division, and the Surgical Society of Kenya, where I'm a member. I must also disclose that in my career, I've consulted for or received honoraria from GSK, PFIZER, and Johnson & Johnson before. Why did we think that we need to touch on skin and soft tissue infections? Is because the current management in our setup is based mainly on traditions, mainly on teachings that we got in medical schools and medical colleges. So if you're in my cohort, you are probably taught about use of flucloxacillin. If you are 10 years younger than me, you are probably taught about use of ceftriaxone. So we thought it better to have a light update on what changes are there, more so for our local scenario. There's also a lot of paucity on randomized clinical trials on SSTI. This is based mainly on the fact that more skin and soft tissue infections are rapidly progressing, rapidly resolving infections. So getting to have data done on RCTs is a little difficult. It's also good to know that classification is getting standardized. Yeah, the risk factors to occurrence of skin and soft tissue infections are getting better understood, and the Kenyan setup for antibiotic resistance is really growing. Skin and soft tissue infections, usually when we say that, we mean mainly bacterial infection of the skin and the soft tissues. They have different names, they have variable presentation, they have a few common features. The progression, of course, of the disease and the systemic manifestations depend on the depth of the infection. There are other causes of skin and soft tissue infections, but for purposes of today's presentation, I'll limit myself mainly to bacterial causes. So my objectives today will be to do a very brief review of the anatomy and how it influences skin and soft tissue infections, review the current epidemiology, review the classification of skin and soft tissue infections, and then go through a few guidelines on diagnosis and management and what has changed in the diagnosis and management. This is a slide familiar to many of us, and if you allow, okay. We were all taught about the epidermis, the dermis, subcutaneous tissues. Just to highlight a few things, the spinal cell layer of the epidermis, yeah, continues into the appendages, yeah, so that you see it going down into the hair follicles and the sebaceous gland. So infections that are limited to the hair follicle, yeah, whether it's furunculitis, carbunculitis, or infections that are around the sebaceous gland are considered to be superficial infections and are managed the same way you would manage the epidermis, infections of the epidermis, with a few exemptions. Yeah. You'll also notice that the blood supply of the skin at the lower part over here is pretty deep. The main arteries and the main vein flow in the subcutaneous tissue just above the fascia. Down here, we would have a fascia. Yeah? That would mean that any infection that reaches the fascia essentially devascularizes the tissues that are above it. Yeah? And that has an implication in the management of these patients. This is an image of a furuncle, which is a single hair follicle infected, and this is an image of a furuncle. Yeah? What is changing in the epidemiology of skin and soft tissue infections? One is that in the developed world, there are reports, multiple studies that are showing that there is the reduction in emergency department visits for SSTI. Yeah? I've cited a study by Edelsberg. I've cited it a few more times before. Yeah? Whereas in the 60s, they had 30–40% visits. By the time that Edelberg was publishing his study, I think this was around 2009, it had come down to 14%. Yeah. Locally, we don't seem to have data on the change of the incidence, because over the last 15, 20 years is when we've had several studies focusing on the SSTIs, and we don't seem to have data prior to that. Yeah? That's why even FONO, when doing a paper for the WHO African office, indicated that there is insufficient data. But data that we do have in the African subcontinent is the increase of community-acquired methicillin-resistant Staph aureus infections. Yeah, and the range. Yeah, so Trong in Botswana gave a figure in the 10s and 20s, but a study done by Maina gave us in 2013 actually came up with one center that even had 87% of MRSA. Yeah? This is high. This is high, and this one impacts on how we should be managing patients with SSTI. Yeah. Then globally now, there is a higher rate of skin and soft tissue infections in males in all forms of SSTIs across all ages, except for the face. Yeah. There's a higher incidence of cellulitis in females. There are higher incidence of cellulitis and erythrocellular in the trunk in females than in males. But globally, if you take them cumulatively, males have a higher incidence. Again, why did we think we need to address skin and soft tissue infections? Yeah? A few things remain the same, that the causes still remain Staph aureus and strep. Yeah? But there's now more of the community-acquired methicillin resistance that we're seeing. Yeah? And then the risk factors are now better understood, both the modifiable and the unmodifiable. This is a paper published by Edelsberg in 2009. Prior to this, there had been a paper done by Simpson, who studied in the US the pattern of and epidemiology and pattern of skin and soft tissue infections over 20 years. Yeah, and he came up with figures, but he did not see any trend, or rather, he did not check or look for any trends in it. So Edelsberg et al. Took 5 years, yeah? Because Siemens published this paper in 2004, 2005. Edelsberg et al. Took it over 5 years and picked a few things, but the most significant one is the younger age group, because previously it was thought that skin and soft tissue infections affect mainly people in the age group of 45 to 64, yeah? But currently, that figure is changing slowly. Yeah, and this is one of several studies that tells you that if you look at the year 2000, yeah, the age less than 15 had 5.7, and the age greater than 65 had 36.7. Yeah, but if you move across a 5-year period, yeah, the age less than 15 has risen to 6.5. The age greater than 65 has moved to 32.3. I'm aware that there's another study that is doing even broader, taking it all the way up to 2015, but I've not seen the results. I was aware that it is ongoing. Yeah? So one of the things that I would like us to pick from here is that we are now getting more skin and soft tissue infections in a younger age group. Yeah? And when we touch on the risk factors, we will see why. Yeah? So known among the risk factors, we have what are called the patient-related one, which are anything that is immunocompromising and giving neutropenia. But the three big ones is diabetes, vascular insufficiency of any form, yeah, especially lymphatic, but any form, be it venous, arterial, predisposes you, and then obesity. The thing about obesity is that obesity actually increases your risk for complication for all forms of skin and soft tissue infections. Yeah? So in this paper published in 2019, et al. Actually found out that for patients with a BMI greater than 30, yeah, they have a 64% risk of having complications. Yeah, and for patients with BMI less than 25, the risk of developing complication or having complicated forms of the disease was as low as 18 to 20%. Yeah. Then of course the location. Yeah. Skin and soft tissue infections, by virtue of them being trauma related, seem to be more on the lower limbs, and actually 58% to 62% of them occur on the lower legs. Then, of course, patients who have renal, liver, or heart failure are more predisposed. On this other column, I was highlighting other things, other etiological factors or other risk factors that would give you a risk of being predisposed to specific pathogens. So in HIV-affected people, we have higher rates of MRSA, we have higher rates of Pseudomonas aeruginosa. In diabetics, the staph A predominates, and they have a few of the gram-negatives. In patients who have animal bites, the Campylobacter. Okay? Then I would like you to share that typically the pathogens above the waist are different from the ones below the waist. So below the waist, you have a higher occurrence of Pseudomonas, E. coli, Campylobacter, and the rest. Above the waist, you tend to have more of the Staph aureus being the causative agent. There have been different classifications on how to classify SSTIs. Yeah? So there have been classifications depending on the depth, whether it's superficial or deep. And when you're saying whether it's superficial or deep, you talk about the epidermal dermis barrier. Okay? Whether it's complicated or uncomplicated. There's one by Aaron et al., which I'll elaborate on. And then the Infectious Disease Society of America tends to divide them into purulent and non-purulent, which I'll also discuss a bit. With all this in mind, the World Society of Emergency Surgeons opted to come up with guidelines for two, so that you could prefer having two criteria. Then I would also want the audience to bear in mind that sometimes when you read about skin and soft tissue infections, there is something omitted. Sometimes people leave out surgical site infection. Yet in reality, surgical site infections are a form of skin and soft tissue infections, only that by virtue of their pathophysiology and what has caused them, we treat them slightly different. But somewhere you need to remember that they are part of skin and soft tissue infections. 3 years ago, the FDA added a small subdivision, what it's called the acute bacterial skin and skin structure infection. But this was mainly for research purposes because there were challenges on how to address RCTs that were coming up. So how would you give out guidelines for RCTs that are coming to dependent on SSI, surgical site infections and the rest. So they came up and lumped everything that is bacterial skin and skin structure as one, but this is basically for research purposes. So remember I mentioned that we would have slightly more depth on two. So I would go to the first one, which is what the World Society of Emergency Surgeons has proposed, that we classify all skin and soft tissue infections into three: into superficial, deep, and surgical site infections. So the superficial ones are the ones that will be limited to the epidermal dermal layer, and then the deep ones are divided into two: the necrotizing one and the non-necrotizing one. So amongst the non-necrotizing ones, you'll have cellulitis, and then amongst the necrotizing ones, you have necrotizing fasciitis and all its forms. And then you have the surgical site infections, which are divided into superficial, deep, and organs. But for us as clinicians, and for how we are going to manage them, a better way is to have the severity staging system. And the World Society of Emergency Surgeons actually gives us 4 stages for all forms of skin and soft tissue infections. So class 1 is where you have no signs or symptoms of systemic toxicity or comorbidities, and we'll address how to diagnose and manage them. 2 is where the patient is systemically unwell with stable comorbidities. So he has no systemic features. He has mild systemic features, but has a comorbidity that would allow for progression into unstable position. So these are the patients who have diabetes, hypertensive, HIV infected. But at that point, the diabetes, the obesity, the hypertension is well controlled. Then you have those who are systemically well, but have a comorbidity, which could complicate or delay. So all these ones, we lump them under class 2. Class 3 are patients who appear toxic and unwell. They have fever, tachycardia, tachypnea, hypotension. And of course, class 4 patients who have sepsis and life-threatening infection or limb severity. If I move on to a little on the diagnostics modalities, this impacts a lot on us in Kenya because we are having more patients with access to medical cover, more patients who are enlightened. We have Dr. Google with us, So we tend sometimes to push our diagnostics for skin and soft tissue infections maybe to one extreme, So what are the guidelines, So for superficial infections, purulent, do you need to aspirate? The aspiration is not recommended except for patients with comorbidity who might have a prolonged progression. You remember we did start and mention that for these patients, these are diseases that move over 5 days, 7 days, short progression. So if you were to do a culture and it takes you 4 days, 5 days, by the time you get your cultures and implement, you might already be on the second last day of your therapy for the patient. So for patients who have superficial infections, you are not recommended to do aspirates. It is not recommended to do blood cultures unless they complicate. And imaging is also not recommended for them. But for patients who have non-purulent, non-necrotizing infections, and I've given examples of cellulitis and erysipelas, aspirates are also not recommended except when you have a recurrence or if 48 hours into your therapy, you have no progression, no improvement. Your patient is still febrile, still has a tachycardia and the rest. So at that point, you have a basis for doing a culture. Aspirate, culture of the aspirate. There's still no recommendation for doing blood cultures, no recommendation for imaging or for doing biopsies. For necrotizing fasciitis, there really is never an opportunity to aspirate necrotizing fasciitis. Yes, nothing really comes out. And even if it comes out, you are unlikely to culture. But you are recommended to do blood cultures. You are recommended to do biopsies. If you go to theater and excise the tissues, kindly progress and do biopsies, both for histopath and also for culture. Then this is the only modality in skin and soft tissue infections where imaging is recommended. And the first line imaging modality is to do an MRI of the affected area. Ultrasound has a role, Radiographs have a role, especially in limited setups. You can do a radiograph, but the first line modality is an MRI. Some considerations as you're managing skin and soft tissue infections in Kenya. One is the changing pattern of bacterial infections, and more so, the higher MRSA levels that you're witnessing. Several studies done in Kenya by Coakley in 2001, by Maina in 2013, by Nyasinga, who published his 2020, are all showing very high methicillin-resistant Staph aureus levels in us. Then, of course, we have positive RCTs. Then, as I have mentioned, we have a growing role of the private sector. We have more patients coming in, access to healthcare, more enlightened. So we need to be more aware with our profile of antibiotics. And of course, Kenya's, maybe Sub-Saharan Africa is one of those areas where you can walk into any chemist and ask for any antibiotic, rising from meropenem to amoxicillin, and you'll be given. So this is data that was shared, that was published by Maina et al. In the International Journal of Infectious Disease in 2013. He did, this was a prospective study across 5 hospitals in Nairobi. Facility 1 is a tertiary teaching and referral hospital. Facility 5 is a teaching and referral hospital. Facility 2 and facility 3 were private hospitals. And facility 4 was a level 4 hospital, public level 4 hospital. What I wanted, why I presented this is that if you look, of course, the numbers are bigger in the public facility than in the private facilities. So you cannot conclusively 100% say that this data is beyond reproach. But if you look at the methicillin-resistant levels, in the public tertiary hospitals, they were pretty high. Yeah. So initially, the thoughts and what we were taught in medical school is that the use of antibiotics had not penetrated that much. It has gone pretty. We are now having a lot of MRSA in the community. Yeah? And this is the same. If you look at the methicillin sensitive, yeah, the numbers were pretty low in these samples taken in the public hospital. Yeah. Okay. Same figure, but this one now is giving us for the different infections, yeah, where the MRSA is pretty high, yeah, in the different forms of. Then Nyasinga et al. In 2020 now compared how the MRSA, methicillin-resistant Staph aureus levels in Kenya have been over the years. Yeah. And from all the studies done, yeah, especially in the Nairobi area. Yeah. If you look at the studies that were done out of Nairobi, Kilifi, this is a bit old, done by Cochlea in Kilifi. There's a single center retrospective. And if you looked at this one done in Nairobi, KISUMU and Kericho in 2015, 2016, the levels are slightly relatively lower than the others done in Nairobi. But again, the other conclusion you get from this table is that if you compare private and public, you have a much higher level of MRSA in the public than in the private facilities. So guidelines on how to manage SSTIs, yeah? So remember, we divided them into purulent and non-purulent, and then the purulent ones, for the mild ones, yeah, kindly, what is recommended now by the World Society of Emergency Surgeons and by the Infectious Disease Society of America is that for these small ones that are mild, an incision and drainage is enough. There is no role for antibiotics. Okay? For those ones that are moderate, or for the ones that are prolonged, you'd have to do incision and drainage, you'd have to culture. And at this point, if you get culture, yeah, then you'd give them, yeah, cotrimoxazole, you have a role for dicloxosaline or cephalaxime. Yeah? But as you wait, there's a role for cotrimoxazole and doxycycline. But where you have severe, yeah, then empirically, you start them either on vancomycin, daptomycin, linezolide, or cefalozine. Okay? Once you have culture, then now you move to the culture base. Kindly note that there's still a big role, yeah, for cefazolin and clindamycin in the treatment of severe purulent infections. Yeah? What about the non-purulent ones? Yeah, and for those of us who will attend to them once they're admitted, most of our patients fall under here. Yeah? So if you have mild, then the role is for oral antibiotic. Yeah? And here you have penicillins, you have cephalosporins, dicloxosaline, clindamycin. Same for moderate, but for moderate now, we ask you to give them on intravenous. But if you have severe, now you move them. Empirically, you start them on vancomycin, you start them on piperacillin, tazobactam, yeah? And then once you have the cultures, now you move. Kindly, again, I want you to note that here, for defined ones, we actually combine. So if you're giving a penicillin, you give it plus clindamycin. If you're giving doxycycline, you give it plus ceftazidime. If you're giving doxycycline, again, you can give it with ciprofloxacin. The mainstay for, remember, for all skin and soft tissue infections, in addition to the antibiotics, surgery has a role. Not really surgery, but you have to evacuate. Remember, we were taught that where it is passed, you drain. So there has been a trend, both locally and globally, to try and aspirate, yeah, needle aspiration of skin abscesses, yeah. And several studies, I think the biggest I came across was this one done by Gaspari, yeah, in the Annals of Emergency Medicine, yeah, which showed that aspiration has a very high failure rate, yeah, especially ultrasound-guided needle aspiration for patients who have what seemed like superficial skin abscesses. In comparison, aspiration gave you 74% recurrence rate versus less than 22% recurrence rate in patients who had incision and drainage. So I would propagate that for now, we still go for open incision and drainage and with the antibiotic cover where necessary. Then there's studies that are looked at the role of wound packing and abscess packing. Again, this is what is in our training. I hope that it's changing with the generations that are behind us. There really is no role in complete abscess packing. What you get with packing of cutaneous abscesses is increased inflammation, increased pain to the patient, and if the abscess is big, you reduce the mobility or the use of the limb by the patient. Okay? What you need to do is to wick, to put something to allow for the pus to drain out of the abscess. But kindly do not pack it completely. Just put something to allow for the pus to drain out of it. A few things about cellulitis, and then a few again about necrotizing fasciitis. The thing about cellulitis, it has, of the skin and soft tissue infections, is the one that has the slowest rate of resolution. Even with the best of care, cellulitis seems to take longer. There are studies that have shown that the average rate of resolution, there's a study done by Pinda in Utah, I think. That was a single center study, showed follow-up and found that the patients on average took 5 to 6 weeks, up to 42 days to have complete resolution. But remember that there are some who have long-term complications, and I'll mention a bit. Yeah. Kindly take care of the comorbidities, yeah, because the presence of the comorbidities tends to prolong the progression of cellulitis. Yeah. And remember the 3 comorbidities we mentioned: diabetes, obesity, okay, and vascular disease. And then look out for high-risk criteria. Then know when to operate patients with cellulitis, yeah? And I'll address that in the next slide. So which are the high-risk criteria for patients with cellulitis, and whom you have to manage as severe, and also whom we advise for surgical excision of tissues or surgical debridement? Yeah? Any patient who has evidence of new altered mental state, any patient who has features of sepsis, respiratory rate above 25, FiO2 greater than, who needs oxygen, yeah, with an FiO2 greater than 40, who needs to be, to maintain saturation above 92, heart rate of 130. Okay? Anyone whose systolic BP is going to be below 90. Anyone who has not passed urine in the last 18 hours, or if he's catheterized, has this less than 0.5. And then patients who have cyanosis as well. What about necrotizing fasciitis? The key about necrotizing fasciitis is early diagnosis. Yeah. And even when you have cellulitis and you have a suspicion of necrotizing fasciitis, you treat it as necrotizing fasciitis until proven otherwise. Yeah. But 3 cardinal signs for necrotizing fasciitis: pain out of proportion, bullae that are darker than the surrounding skin, and no response to therapy in the first 48 hours. Yeah. When it progresses, and sadly some of our patients come when it's really progressed, then they come with crepitus. At that point, imaging helps you. Okay? So this is a radiograph of a patient who was coming with necrotizing fasciitis, and you can see the hypodensities in between that are consistent with air in the tissue. The great thing about cellulitis or necrotizing fasciitis, do not be worried if your initial debridement is not adequate and you have to do more. Do it as thorough as possible on the first time, but remember, you may be required to do serial debridement. Then kindly remember, that the blood supply of the skin passes in the subcutaneous tissues just below the main vessels are there. So the skin up would for a while look healthier than the real damage, okay? So what we ask you is that when you're debriding, remember that even skin that looks healthy at the edges will be revitalized. So the request is your excision should be wider than the tissue of the skin that looks like it's affected, okay? So in summary, if allowed, is that for superficial purulent infections, there's no role for cultures, there's no role for antibiotics, incision and drainage is enough. If the superficial ones have a recurrent infection, then you move them to oral. For the non-purulent ones, yeah, if they're mild, there's no role for cultures. Move them to oral cephalosporins, move them to clindamycin. it's moderate, we have cultures, we have parental. If it's severe, we have cultures, we have imaging, and we have parental antibiotics. A few more, remember that for necrotizing fasciitis, it is rarely now that you have monoclonal species, that most likely they are polymicrobial. These are my references, and I want to thank you. Back to Dr. Onyango.
Thank you very much, Caesar. Very wonderful presentation. I encourage members who have questions, please post them using the Q&A icon or in the chat icon. At this moment, I'm going to invite Amos. Amos is going to make a presentation on behalf of our sponsor. I know there may be some burning questions, but please, let's just be patient. Let us answer them after Amos has given his presentation. Karibu, Amos.
Thank you very much, Dr. Onyango. Thank you very much, Dr. Caesar, for the informative session. I really appreciate these opportunities. It's an honor to be part of this team. Good evening, doctors. My name is Eugene Kiptum, like what Dr. Onyango has said. I work for PFIZER. At PFIZER, we've built a tradition of bringing in breakthroughs that change patient lives. One such breakthrough is Dalacin C, an antibiotic that has been, it's time tested. It's been in the market since the early 80s. So for the aim of this evening discussion is to highlight a few features of Dalacin C, which includes its high tissue penetration, its proven efficacy, as well as its dosing. So PFIZER does not suggest or recommend the use of any of our products in a manner that is described, in any manner that is different from what is described in any of our prescribing information, which is usually approved by the local authorities. So this highlights what Dr. Caesar mentioned about. Most skin and soft tissue infections are usually polymicrobial in nature. And the notorious ones are usually the anaerobes, which are clinically important in the sense that they tend to occupy parts of the tissues that are difficult to access. And in this particular study, it showed that if you look at some tissues, some infected tissues, especially in the case of abscess, the anaerobes could be even more dominant compared to the aerobes. And this, in a way, should guide the choice of an antibiotic. It's polymicrobial in nature, but on top of that, it tends to be dominated by the anaerobes. So in such a sense, the choice of antibiotic should be the one that has a very broad spectrum and is able to take care of the anaerobes, which are usually occupy difficult to access tissues. Dalacin C, which is the original clindamycin, has been shown to have a very broad spectrum. It covers both the aerobic bacteria as well as the anaerobes. And especially the notorious one in the skin and soft tissue infections, the staph aureus, and also the strep, the gram-positive bugs, they are well covered by the Dalacin C. On top of its very broad spectrum cover against the anaerobes. So this, we are trying to compare the Dalacin C with other antibiotic options. One of them is a penicillin combination with a beta-lactamase inhibitor, that is amoxiclav, as well as metronidazole. And as you can see, the cover of Dalacin C is very broad. It covers both the aerobic as well as the anaerobic bacteria. And also within the subclass, if you look at the bacteria that is covered, it's a more broader cover. Compare this with metronidazole, which has a good cover against the anaerobes, but no cover against the aerobic bacteria. On the other hand, amoxiclav has a very good cover against the aerobic bacteria, but almost no cover against the anaerobic bacteria. So in this sense, for skin and soft tissue infections, this means that you can use Dalacin C on its own without adding any other drug, any other antibiotic, and still achieve the broad spectrum cover. And like I mentioned earlier, the significance of the presence of the anaerobes cannot be underscored, on top of the fact that in most, like what Dr. Caesar mentioned, the Staph aureus is quite dominant in skin and soft tissue infections. So a broad spectrum antibiotic would be an ideal choice in such a case. So Dr. Caesar really emphasized on the increasing presence of MRSA, and Dalacin C has been shown to have a very strong cover against the MRSA, on top of even in the methicillin susceptible ones, it still covers, but even better still, it covers the MRSA, the community-acquired MRSA. In this study, it compares the use of fluoroquinolones, erythromycin with Dalacin C. And Dalacin C was shown to be efficacious 95% of the time. And these were patients admitted for skin and soft tissue infections. And Staph aureus was found to be present in 76%, which in a way, like what Dr. Bita mentioned, could be reflective of what is happening in our setting. The ever-increasing cases of MRSA necessitates the use of an antibiotic that takes care of that. And in such a case, Dalacin C would be an ideal antibiotic. So other than the broad spectrum, Dalacin C has been shown to get into the tissues. You can have a very good antibiotic, but if it's not able to get into the site of infection, you wouldn't achieve the desired clinical result. Dalacin C has been shown to achieve very high concentration, even in tissues that are difficult to access, like the bone, where it achieves 70%, up to 70% of what is present in the serum, which is quite high. And this is even after oral administration, because it has a very good oral bioavailability of 90%, which is almost the same as when you give it parenterally. So that really makes it easy to switch from parenteral to from parenteral to oral formulation. You can easily switch without losing the efficacy, because it still penetrates to the site of infection. This emphasizes on how Dalacin C first distributes, as well as concentrates into the various tissues of the body. You can see the red one signifies the skin, the blue bone, as well as the presence of the concentration is in the fatty tissues, represented by the color green. And this highlights that immediately after administration of Dalacin C, which is stipulated by 0 in there, all the way to 8 hours after administration, you still have the concentration of Dalacin C way above the yellow line down here signifies the captures the concentration captures the MIC level of Staph aureus. So if you see immediately after administration, all the way to 8 hours, you still have the concentration of Dalacin C in the important body tissues, the skin, the bone, as well as the fatty tissues, way above the MIC of Staph aureus. That means that by the time you're giving the next dose, you still have sufficient amount of the drug in the tissues to take care of that. So there's no gap in between. So if you look at Dalacin C, is usually given 3 or 4 times daily. So before you give the next dose, you still have sufficient amount of the drug in the tissues to take care of the to achieve clinical results. So the concentration you can see in the skin is usually way high, even at times higher than corresponding plasma levels. So on the dosing of Dalacin C has a very flexible dosing, depending on the severity of the infection. In adults and children above 6 years, the recommended dose is between 600 mg to 1,800 mg daily dose, which you can give twice, thrice, or 4 times daily. For pediatric patients, the dose is usually between 8 and 25 mg per kg per day in 3 or 4 equal doses. And just to mention, the available formulations of Dalacin C that we have in Kenya, we have the capsules, which is available in 150 mg as well as 300 mg. We also have the parenteral formulation, which you can give either as IV or as IM. So in such a case, and also for pediatric patients, we have granules for reconstitution, which come in 75 mg per 5 ml, 80 ml a bottle. So it's very flexible depending on the age of the patient and the severity of the patient. You can use the most appropriate formulation in that. And if switch is necessary, once the patient maybe is in a better condition, a patient who was admitted, you can easily switch to the oral formulation. So for the parenteral solution, you can go into higher doses. Doses of up to 2,400 mg is still okay. Daily dose is still recommended for parenteral for the severe cases of the disease. And another very good attribute of Dalacin C is you do not require any adjustments for patients with renal impairment or hepatic impairment. Even for elderly patients that have age-adjusted normal hepatic or renal function, you do not require any renal or hepatic, any adjustment in such a case. You can maintain the normal adult dose in such patients because it's quite safe in such a setting. In summary, we've seen that Dalacin C has a very broad spectrum cover. It covers both the anaerobes as well as the aerobes. And I mentioned that Dalacin C has a bioavailability of 90% from in vitro studies. This tells you that even if you give it orally, you still achieve quite good concentration into the infected tissues. And also the rapid and the wide distribution of Dalacin C in the tissues is a factor that you cannot underscore. The fact that it gets into very difficult to access infected areas such as the abscesses makes it an ideal antibiotic for skin and soft tissue infections. Also, the fact that you can give it as a monotherapy because of the broad spectrum cover could reduce the cost of treatment, as well as the pill burden and the risk of adverse events, which is brought about by using more than one antibiotic. And Dalacin C is recommended by many international guidelines, including the IDSA of America, as the first-line drug for use in soft and skin tissue infections. And we mentioned about the flexible dosing. You can go up to high doses it has a very large window of safety. So you can still achieve your efficacy without compromising without increasing the risk of side effects brought about by the drugs, which is very common when you use some very potent drugs like Dalacin C. So, doctors, considering the very positive attributes of Dalacin C, my ask from you is to pass these benefits to your next patient presenting with a presenting with a skin or soft tissue infection. So thank you very much for your time and attention. I welcome any questions relating to Dalacin C. Have a good evening. Back to you, Dr. Onyango.
Thank you very much, Amos. Another wonderful presentation. I think we'll start with the questions. Dr. Bita, we have a question which came in quite early from Martha Achieng. What is the best antibiotic for SSTIs in special population? For example, animal bites. I think that may also include humans. I think there are also animals who can give very dangerous bites. Cat scratches, fever, cat scratch fever, human bites, and the rest. Please, you can start with that. The best antibiotic in case of in a special population, yes.
So Martha, to go around all these, we would ask you to go back to the guidelines that is given, and you would treat these ones mainly as moderate non-purulent infections, which means that your choices would be clindamycin, cefazolin. Yeah? In the absence of those, you're actually allowed to start off with ceftriaxone. Yeah. So don't feel too guilty. I saw there's also another question in the chat about somebody who feels too guilty about use of ceftriaxone. If you stage the disease into mild, moderate, and severe, and your patient is falling into this special risk group, or you remember when I was talking about the World Society of Emergency Surgery classification, staging severity system, and they fall into stage 2 or stage 3, where they have a systemic comorbidity, then you actually start them with these intravenous antibiotics. Yeah? But if they have mild disease, give them oral antibiotics, or if they have just a purulent skin disease, you don't need to give them any antibiotics. I hope I've answered you.
Thank you, Caesar. Then along the same line, thank you. I think you've also answered the question of our former student, Dr. Kevin Okoth. Thank you, Daktari. We are glad that we've spread our wings. Dr. Eli Kutwa is asking about the role of vacuum dressing when you are managing chronic wounds, and at the same time, what would be your take, as asked by Dr. Somba Kivungu, about use of sofratule for dressing and packing of abscesses?
Okay, let me start by the second question. Yeah, I would really discourage the packing of abscesses. I would want you to put, if you can, sofratule is the best thing. Take a piece of sofratule, put it into the hole, let it allow the hole, the cavity, to remain open and allow for continued drainage. Yeah. In the absence of sofratule, take a small piece of gauze, because gauze is what is available in most public sectors. Yeah? Take a small piece of gauze, but kindly do not use it as something to pack. You are using it to give you a passage. Okay? So if you have something that is as less absorbent as sofratule, that would be good. But if you have something that you don't have that, have something, a string, a wick. Remember, we use the word wicking on it to allow for passage, but try to move away from the packing of the wounds. Yeah. And then there's a question on the use of vacuum dressing. Kindly, vacuum dressing is best done after debridement. So if you have a patient who has a chronic ulcer, meaning that you do not have sufficiently good granulation tissues without it, you will not achieve, because what vacuum does is to allow for, reduce the bacterial flora and growth in it, but also allow for reduction in the size of the wound. So if you can, yeah, it's allowed for all tissues, but after a debridement, so that you have a healthy tissue below you. Can you modify vacuum dressing? There are ways of modifying it. You'll allow me to use, I hope everyone in the room is Kenyan, so when I say kienyeji, everyone understands what I mean. So the local way of modifying vacuum dressing is by use of cling film. Yeah, and I know there are many members in the audience who have used cling film, where you just use the same gauze, use a colored substance. In our setup, we use mainly iodine, not as an antiseptic, but to allow us to see that the vacuum is working, because as long as the iodine is being absorbed from the tubes, it shows you that the vacuum is still working. Okay? And then you put layers of gauze, you put Sofra2 layers of gauze, then you can put cling film. Cling film is what you buy in the supermarket for 200, 300 shillings, and it can serve for you the same purpose. So I hope I've answered them adequately. Kindly unmute Dr. Nyango.
Thank you very much, Caesar. As you take a small break, I think we'll ask Amos something so that Amos, the question is, can Dalasin C be used in as a monotherapy in cases of chronic osteomyelitis?
Okay, thank you very much, Dr. Onyango. Thank you very much, Dr. Simiyu, as well, for that question. I think for considering the chronic nature of osteomyelitis, I would suspect in such a case, you'll be able to do maybe a culture to give the profile of how the infection looks like. And I think that would determine if monotherapy is necessary or not. But Dalasin C is usually indicated in osteomyelitis. And I think it's one of the indications that has been used for many years. But I would love to hear from Dr. Bita as well, how it is in actual clinical practice. Is monotherapy the most common practice, or combination therapy?
Okay, I'll start by declaring that I tend to move away from bonds. I have moved away from bonds for years. But from the experiences of colleagues, I actually do see them using it a lot as monotherapy. But that is not an authoritative answer for it, but I've seen it being used as monotherapy. Yeah. Then Dr. Nyango, you'll allow me to pick to answer a question asked by Martha Awiti. Yeah. Because Martha Awiti asks that
Go ahead.
They've been taught that clindamycin is a last resort antibiotic for patients who have MRSA. I think I've highlighted throughout this presentation that we have tended as a region, sub-Saharan Africa, to deplete our options. So the level of MRSA that we're having now is much higher than what we had 20, 30 years ago. And so the use of flucloxacillin, because an attendee has also asked that, is less and less beneficial. The prolonged therapy, the poor outcomes that you're getting with patients who have flucloxacillin are rising. So we, in view of these high levels of MRSA and resistance to flucloxacillin, we want you to move away slowly from using flucloxacillin as your first line. Yeah, we want you to look for other options. And sadly, as a result of that, the options that you are left with are cefazolin, clotrimoxazole, and clindamycin. Yeah. So do not consider clindamycin as your last option. It would be best in patients who have moderate and severe, and patients who have prolonged progression, that you should be able to get cultures, yeah, and get definitive therapy for them. That would be the best, yeah. But if you get a patient walking in, has cellulitis and has all the features of severity, or the high risk ones, or the patient has necrotizing fasciitis, I would really not advise you, seeing that we have up to 70-something% of community-acquired MRSA, to start with flucloxacillin. I would advise you to move higher.
Another thing is that Dr. Carrier is asking you that, do you know of any role of honey mixed with ghee for dressing of wounds?
Dr. Carrier, I know that is off today's topic, and I am biased in that because I know there is a member in the room who did a study with the use of honey in Migori County Hospital with very good results. I have seen 2 other people who have been in multi-center studies where it was one of the arms. So yes, but kindly look for me to advise you on which honey. Yeah, because do not send your patient to buy honey at the supermarket to apply on the wound. There are specific forms of honey, specific species. In the absence of that, locally we can tell you this form of honey to buy. Yes, but there is a role for the use of honey in significant or large wounds. Yeah? But you'll allow me not to go further because it's beyond the scope of today's CPD.
Okay. I think Martha will request that if you are at Uzima, please have an opportunity, and when you meet Dr. Bita in the corridors of JOTRH, you can engage further on SSTIs. And probably Bita, there you have a budding surgeon for you to mentor so that he will take over from you when you retire, or you can work together. Please receive some greetings from your former student, Ramco, and the rest. They are thanking you for a good mentoring session. I think for now, we will stop the questions for now, and we will request that if there are any others, probably we will have them, and we can always never miss an opportunity to have your questions being answered. My role was later on to come and give a summary, but I think we have other senior KMA members who are in the room, and we will not lose that opportunity to give them a chance to address the members of the fraternity. Dr. Simon Kigondu, if it is okay with you, I would like to cede the field to you. Kindly address the doctors, and you are not restricted to SSTIs. You can also give a point on vaccination and encouraging pregnant and breastfeeding mothers to get the COVID vaccine as you talk about other KMA matters. And I would gladly let you officially close the sessions after you have given your remarks. Thank you very much, members, for attending.
Thank you very much, Kennedy. Thank you very much, Kennedy. And I think we have had it all. And I love your introduction. And for me, it's only to reiterate that Kenya Medical Association has divisions all over the country, and people have to look for the division nearest to them and join. We are also online on kma.co.ke, and our payment renewal per year can be done via M-Pesa using the same platform. But the pay bill number is 645645, and you put in your name and you are a member. We'd like to encourage members to actively participate. Our strength is in CME, as you have seen what Kennedy has coordinated, and we work a lot with the pharma industries. And I want to thank PFIZER for their facilitation and also for the products that also help doctors manage their patients. In matters COVID vaccination, Kenya Medical Association and Kenya Gynae Association is encouraging, one, the Kenya government to actually bring in the COVID vaccines. And two, we encourage all members and members of the public to get vaccinated. Recently, we have upped the stakes and encouraged that even pregnant mothers should get vaccinated. We are seeing a lot of severe COVID in pregnant mothers, and we should take this opportunity to encourage them to get vaccinated to prevent severe COVID. And with that, I think I would allow all of you to keep in touch with our social media pages to get to know when our next CPD and webinar sessions are. And with that, I think I can declare the meeting officially closed. And thank you very much, Dr. Bita, and the rest of the team, and the good work that is going on at Maseno. Thank you very much to everyone. We'll see you next time. The CBD points will be sent to your email addresses.